continue to be major global public health threats, affecting almost 500,000 Canadians and causing more deaths around the world than HIV, tuberculosis, or malaria. That's the bad news. The good news is that we have a cure for Hep C and a vaccine to prevent hepatitis B. We have the tools and the know-how to eliminate these public health threats in Canada. Canada, along with countries around the world, has committed to achieving this ambitious goal by 2030. Taking on something as bold as eliminating a disease takes a lot of coordination. This is a marathon. It's definitely not a sprint. Any runner will tell you that it is the last few miles of a marathon that are the hardest, but also the most important. Because hepatitis causes liver damage and liver cancer over many years or even decades of infection, it rarely grabs the headlines like an infectious disease like COVID does, but that makes it no less urgent. Before the pandemic, Canada was on track to meet these ambitious elimination targets. With everything going on in the world and the pressures on resources everywhere, we've gotten off track. We are here today to remind Canadians, and particularly our governments at the federal, the provincial, the territorial, and even the municipal levels, that we have come a long way in this race. And as we can now just start to make out the image of the finish line off in the distance, it's not time to slow down. It's time to redouble our efforts. These last few miles will be the hardest of the race, but if we don't stay committed, we will lose all the progress that we've made. We have remarkable leadership, passion, and expertise across this country with clinicians, scientists, public health officials, community members, people with lived and living experience, all driving towards a common goal. We need continued support to help us get to the finish line. Let's not stumble now. We've come a long way already, but we will lose all of our momentum and progress if we stop now. We need to keep working to prevent infections and increase our efforts at screening to find every person living with hepatitis B and C so we can connect them to care and treatment. We are here today to remind ourselves and our leaders that with collective effort, we can eliminate viral hepatitis as a public health threat by 2030.
Thank you, Jordan. Good morning, and thank you for being here to mark the 5th Annual Canadian Viral Hepatitis Elimination Day with us. I'm Jennifer van Gennip, Executive Director of Action Hepatitis Canada. We're a coalition of over 80 community-based organizations united in one goal: to hold federal, provincial, and territorial governments accountable for their commitment to eliminate hepatitis B and C as public health threats by 2030, a promise made to the World Health Organization and to every person in this country. Today, we are releasing our report entitled Rethinking Viral Hepatitis Prevention, Confronting Systems that Create Risk. This report comes out of a key finding of our 2025 progress report. While governments across Canada have expanded access to hepatitis C treatment, several have also made decisions to scale back evidence-informed prevention programs. This report gives particular attention to hepatitis C because reducing new infections remains Canada's weakest viral hepatitis elimination metric. We are failing to meet essential targets for reducing new infections. The 2030 World Health Organization target is no more than 50 new cases per 100,000 population, but Canada sits at 19, almost 4 times that target, and that gap is the result of policy choices about prevention. But rates of hepatitis C transmission are not evenly distributed across Canada. Individual provinces report new case rates of up to 32 per 100,000, and individual public health units report up to 139 per 100,000, or 28 times the World Health Organization target. When hepatitis C transmission clusters like this, it tells us something important. Risk isn't random. It's shaped by policy. The good news is that policy can change it. Our work is rooted in health equity. Hepatitis elimination can't just be about hitting targets. We must also ensure that no one is left behind because of where they live, the color of their skin, how much money they have, or the stigma that they face. And that means designing systems that work for everyone. Hepatitis C is now curable, and hepatitis B is treatable. But let's be clear, it's still better to not get them in the first place. We are urging governments at every level, get serious about prevention. This means restoring and expanding the evidence-based programs that we know reduce transmission of hepatitis C and other sexually transmitted and bloodborne infections. Harm reduction is hepatitis C prevention. When we lower exposure to any spreadable disease, it improves public health for everyone. Across the country, dedicated healthcare providers are doing everything they can, but they are working within systems that don't always give them the tools that they need to prevent new infections. Our report is now available at actionhepatitiscanada.ca/rethinking prevention. I'm going to invite my colleague and friend Janet Butler McPhee to expand on a few of the environments that shape hepatitis C risk next. Then we'll hear from Dr. Curtis Cooper on hepatitis B prevention, and Jody Jollimore will have some closing remarks. Thank you.
Good morning. Thank you, Jennifer. My name is Janet Butler McPhee. I'm the co-executive director of the HIV Legal Network. We're a health justice organization that upholds the human rights of people living with HIV and hepatitis C, as well as those subjected to punitive laws and policies that shape, in very negative and insidious ways, their daily lives. We're a long-time and proud member of the Action Hepatitis Canada Steering Committee. On this viral hepatitis elimination day, it has never been more important to speak about risk environments and how HCV, HIV, and other STBBIs are needlessly transmitted within these unsafe environments. As our report indicates, we know that transmissions follow patterns in access, or lack thereof, to safer drug use equipment, testing, treatment, stable living environments, and culturally safe supportive care. Personal choices are not the problem here. Risk environments within unsafe systems are. One of the most obvious risk environments where hepatitis C, HIV, and other STBIs can and do take hold is within carceral or prison settings. People who use drugs exist within a colonial system that surveils and criminalizes them at every turn. And in Canada, prisoners face far greater risk and are 40 times more likely to be exposed to hepatitis C than the general population. Colonial policy environments also mean that Indigenous people are overrepresented in prison populations, the result of failed systems in and outside of prison walls. But taking a step back, we must always remember that people who enter prison do not somehow forfeit their right to health care. As clarified by the Mandela rules, people in prison have the same standards of health care that are available in the community. This is often called the principle of equivalence. In other words, incarcerated people must be provided health care without discrimination based on their legal status. And that health care must be consistent with what is available within the broader community. Moreover, because people's ability to protect their own health is constrained in prison, governments have even more of a duty to prioritize health care in prisons. Canada is falling short of meeting these health and human rights obligations. The system is not working, but it could work. Our report today highlights the many ways that carceral settings function as a serious risk environment. We know that people living with hepatitis C may never have had access to treatment on the outside, and that some will lose access to their treatment upon prison entry. Access to voluntary testing may or may not happen. Access to a prison-based needle and syringe program is inconsistent at best, as it exists in only 14 of 43 federal institutions, and there's no such program available at provincial and territorial institutions. And recently, access to certain opioid agonist therapies, life-saving and life-changing, is becoming more restricted. All of this contributes to a risk environment that is just getting riskier. When people leave prison, they may or may not be connected to any healthcare within the community and may or may not be able to access adequate harm reduction services. Thus, the systemic risks proliferate, encountered at each and every turn. The delivery of comprehensive and equivalent hepatitis care in and out of carceral settings is key to ending new transmissions and upholding human rights for all. But, as my colleagues have said, with better policy choices and human rights and public health at the fore, we can make real positive change and meet our goals here in Canada.
Good morning. I'm Dr. Curtis Cooper. I'm head of infectious diseases at the Ottawa Hospital and professor of medicine with the University of Ottawa. I'm grateful for the opportunity to talk about viral hepatitis this morning. What I'm going to focus on is one of the great triumphs of prevention with hepatitis B infection, and that is the hepatitis B vaccine. This vaccine has been with us for decades. It's been administered to millions and millions of individuals over that time. It has a superb safety profile, and it has an excellent benefit in providing lifelong protection to hepatitis B. Our goal in eliminating hepatitis B is to encourage all nations to fully vaccinate their populations, which in a generation or two will result in the elimination of hepatitis B globally. The vaccine is safe, it's well tolerated, it's inexpensive, it works whether you live in an urban setting or a rural setting. It works irrespective of your financial status, other health conditions, race. It's an excellent, tried and proven strategy to avoid hepatitis B. Now, the WHO recommends birth dose vaccination. That means as soon as baby is born, we start the immunization series. This is important because if you do it at the time of birth, it reduces and basically eliminates any opportunity for that child to fall through the gaps and not be vaccinated for hepatitis B. In Canada, we have a patchwork of approaches. Some provinces and territories provide birth dose vaccination, which we fully endorse. Other provinces and territories delay the immunization until later on in childhood or in the teenage years. Although it's great that everybody gets an opportunity to be vaccinated at any time during their lifetime, we would like to see Canada have a unified approach to immunization where birth dose vaccine is provided to all newborns across every province and territory. And we strongly encourage all levels of public health and all levels of policymakers to align with this, which will help to enable our efforts to eliminate hepatitis B from Canada as well as globally. Thank you.
Thank you, Dr. Cooper, and thank you to Action Hepatitis Canada for inviting me. My name is Jody Jollimore. I'm the Executive Director of CATIE, Canada's source for HIV and Hepatitis C information. And it's my job to ensure that people have the information they need to prevent, diagnose, and treat infections like hepatitis C. Those people include healthcare providers, people at risk, and people affected by the virus. But that also includes decision makers, because the fact is that no matter how many advancements we make in hepatitis C research, from highly effective prevention methods and state-of-the-art testing to the first chronic viral infection with a cure, none of that matters unless those in charge of policies and funding make them accessible. And for too many Canadians, these groundbreaking advancements are still out of reach because of policy decisions. Across the country, we're seeing governments restrict programs that are proven to reduce the risk of hepatitis C. Programs like supervised consumption services and needle and syringe programs. We also have technologies that can diagnose hepatitis C in less than an hour, and these technologies are waiting to be rolled out in community settings. And because coverage of hepatitis C treatment is only possible through a patchwork of public drug plans and compassionate access programs, some of the most marginalized patients in the country are falling through the cracks of bureaucracy and application forms. For a country like Canada, which considers our universal public health care system to be a point of national pride, we should not be one of the laggards. We should be reaching our international viral hepatitis elimination goals. And that isn't going to be the case unless decision makers responsible for the health of Canadians prioritize evidence-based policy over short-term politics. And I like to remind policymakers that while these are international targets, the people impacted, they're Canadians. They're our citizens. And we're letting them down. The scientists, healthcare providers, and community workers on the front lines are ready to help eliminate hepatitis C in Canada. We're looking for more than declarations. We need decision makers to do their part as well. Thank you.
Thank you. Merci. We don't have any questions at the moment. Il n'y a pas de questions pour le moment. This concludes the press conference. C'est ce qui met fin à cette conférence de presse.
Thank you.
Thanks.